So thank you very much for having me. My name's Ben. I'm a clinical specialist physiotherapist in the long-term ventilation team based at Glenfield Hospital. So Lee, one of the physios on ICU at the Royal, just asked me to come and do this session that I did for the physios at the end of last year. So I'm going to talk a little bit about respiratory care in patients who had a spinal injury, both acutely and long-term. So starting with a little bit, I guess, of revision very quickly. We obviously know that in a spinal cord injury that's complete, the muscles which are below, the muscles that are innervated below the level of injury obviously aren't going to work. So when we think about breathing, we know that the diaphragm is innervated by C3 to 5, and that's responsible for around about 70% of tidal volume. Your scalenes are innervated by C3 to 8, and they're your inspiratory accessory muscles, or one of. Your pectorals are around C5 to T1, and they obviously help to lift the ribs up and out. And then lower down, coming into the thoracic spine, T1 to 11, and then T6 to 12 are your intercostals and abdominals, which are helpful for active exhalation and coughing. So why do spinal cord injuries affect your breathing, aside from the obvious? Well, we know that regardless of level of injury, even if you have got the diaphragm intact, you're going to have some respiratory muscle fatigue. So if we think about, your maybe C6, C7 injuries where you've got diaphragm intact, we know that if the intercostals and other inspiratory muscles aren't working, that the diaphragm is going to be much more fatigable. So in these patients, when respiratory load increases, they are more susceptible to fatiguing and going into respiratory failure. We know with these patients that sitting upright causes a disadvantage in the acute stage because the diaphragm doesn't have any tone, and that the best position is to lie them flat in bed with a maximum of 30-degree head up. And that can increase vital capacity by up to 6%. We know that spinal shock post-injury leads to flaccid paralysis, which is the loss of tone below the level of injury. And we also know that these patients are at high risk of obstructive sleep apnea because of changes in lung volume, muscle weakness, and changes in the upper airway. As I said, we expect them to have reduced lung volumes, and we also know they're going to have an impaired cough and ability to clear secretions. And finally, we obviously need to think about auscultating these patients as with neuromuscular patients. If air entry is poor, they might well be full of phlegm. But if you've not got any air passing over the secretions, you're just going to hear quiet breath sounds throughout, even if they're full of phlegm or got a raging infection. So a lot of what I'm going to talk about today is, I guess, feedback from a course that I went on last year that was run by a group called the RISCI Group, which stands for Respiratory Interests in Spinal Cord Injuries. So the group's made up of representatives from specialists, either consultants, advanced practitioners, or physios at the spinal rehab centres in the UK. So these are the spinal centres in the UK up on screen at the minute. Obviously, here in Leicester, our patients would go to Sheffield, unless they were a Northampton patient, in which case they'd go to Stoke Mandeville. And so this day that I went on was mainly based around the team at Stoke Mandeville's experiences of managing patients because they ran the course. So I'm just going to share a little bit of what they raised. So the first thing that they spoke about is what they call the pitfalls of pre-admission. So the things that they think go wrong before patients get to them, Stoke Mandeville or Sheffield or any other of the referring centres. And they said that when they thought about patients who have ventilation, usually tracheostomy ventilation, when they get to the spinal centre, 2/3 of those patients on arrival at the spinal centre require what they call a rescue. And they attribute the causes of that being weaning too quickly and too aggressively, basal collapse and consolidation, and comorbidities. They said that the third of patients who didn't need rescuing on arrival were typically patients who were younger, who were 24-hour ventilated because of the level of their injury, and they had a short length of stay at the referring hospital, so they probably weren't as far down the weaning route. Their recommendations for weaning patients, we will come on to weaning spinal cord injury patients in a minute, but their recommendations were that the patient be in pressure control mode, that we aim for a tidal volume of 7 to 15 mils per kilo of ideal body weight, which is massive. 15 mils per kilo of ideal weight feels really big, but they argued that the reasons they would aim for that are to reduce the risks of atelectasis and collapse, which they felt would give them the best chance of successful weaning. They wouldn't consider any weaning until the patient had a clear lung field on an X-ray, so no consolidation, no basal collapse. They would strive for cuff down ASAP to facilitate upper airway so that the patient can talk, to help facilitate swallow. They wouldn't do any weaning when the patient was infected. So if the patient's CRP went up, or if their white cells were off, or they were spiking in temperature, then weaning would be stopped, and they wouldn't be progressed. That doesn't mean to say that if a patient was only overnight ventilation or just using it for bits of the day, they would go back to 24-hour ventilation. They just wouldn't progress their weaning. They stress the importance of optimizing their airway clearance through nebulizers, mucolytics, chest physiotherapy, and they really emphasize the need for fatigue management with rest overnight. They did speak quite a lot about prioritizing weaning in their eyes, and the fact that actually they would prioritize weaning over things like rehab, which is possibly quite a controversial opinion, but they felt that by allowing the patient to conserve energy between weaning periods, they had a better chance of weaning off the ventilation. And the last thing they stressed was to avoid cuff up when off of the ventilator. If anyone has any questions, feel free to just put your hand up as well, by the way, or comments or thoughts. So the next thing that they had to talk about on the day was a trial that was completed up in Glasgow at Queen Elizabeth Hospital, which is one of the spinal centres, and they completed a PDSA, which they called the bundle. So they completed this for all of the patients who arrived with an acute spinal injury are complete or incomplete of T1 or above, unless it wasn't deemed appropriate, by which they meant that the patient was intubated on arrival. In the first 7 days after arrival to their Queen Elizabeth Centre, every patient of T1 and above would receive 4 times a day bronchodilators, 4 times a day carbocysteine, 4 times a day physiotherapy in the means of manual techniques, cough assist, manual assisted cough, whatever was deemed necessary. The nursing staff would also do cough assist 4 times a day. They would do 4 one-hour periods of non-invasive ventilation. And when the patient wasn't on an IV, they would use a nasal high flow. And their theory behind doing this was that it would reduce the risk of respiratory complications. So it would reduce the number of patients who had basal collapse or infection, and it would hopefully reduce their intubation rates. They understandably came under a lot of reluctance from staff who perceived that it was a significant increase in workload and that it stretched them outside their comfort zones. And to help accommodate this, there were preset prescriptions for cough assist, nebulizers, and NIV settings, so that nursing staff who were sort of on the shop floor and admitting these patients didn't have to clinically reason what settings to use. They could just set them up, and then from there, if it needed to be titrated or adapted, it could be. And the results were really interesting. So they found that when they did their audit before they launched this bundle, 5.1% of their patients with a T1 or a higher injury were intubated. And of those patients, 44% of them required a tracheostomy. Post-bundle, so after this 7-day period, only 3.6% of their patients were intubated. And of those who were intubated, 64% of them required a tracheostomy, which they argued showed a reduction in unnecessary intubations because the patients who were tubed went on to have a tracheostomy, so did need to be intubated. They also felt that it helped to improve safety because patients were managed in hours and there were less out of hours patient deteriorations and intubations. They also noticed a reduced intubation by day 7, and the average length of time a patient was ventilated for increased from 18 days to 27 days, which they again felt highlighted that it avoided unnecessary intubations. This is something they still continue to use now post-trial, and they do this with all of their T1 and higher injuries, and they are looking at adding to the bundle by making future plans to put in prophylactic antibiotics in those first 7 days. Okay, so coming on to talk about weaning from ventilation. We know that as time passes, weaning becomes possible because of resolution of cord edema, because flaccid paralysis turns into spasticity, which can increase muscle tone and change chest wall compliance, because intact intercostal muscles will be retrained, and because patients have a tracheostomy, which makes weaning much more easy and possible. These were the prerequisites that the team at Risky felt were necessary before they would consider weaning a patient from mechanical ventilation. So they would aim for a PEEP below 5, which we will come on to talk about in a little minute, because there is some audit data which suggests that higher peaks can be weaned from. But their argument for that was that that reduces the risk of atelectasis and basal collapse when the patient's taken off the vent. They wanted the patient to be delirium free. They needed to see evidence of spontaneous breathing on the ventilator. They wanted the patient to be infection free and have clear lung fields and have an FiO2 of below 40%. I'm sure people have seen this before. So this is the Southport weaning guidelines, which most centres in the country use. And the message from Risky was that this is the performer they would like patients who were referred to them to be using in the pre-admission phase. So the Southport weaning guidelines are based on a patient's vital capacity completed with handheld spirometer, and the duration of ventilator-free time is then dictated by the size of vital capacity. So, for example, a patient with a vital capacity of 250 mils would, on day 1 of weaning, do 5 minutes of ventilator-free breathing. If that was successful, that would then progress to 10 minutes the next day, 20 minutes the day after, and so on. In between those periods, the patient would be rested, and eventually that would then increase to 2 sessions of weaning a day, and so on. Conversely, patients with a much higher starting vital capacity have a quicker weaning guideline. So patients with a vital capacity greater than of around a litre would start with an hour on day 1, progress to 2 hours and 3 hours, and again, so on. An audit completed by Southport Hospital found that a high peak wasn't actually detrimental to weaning. So that's something that can be considered on a patient-by-patient basis. And they also found, unsurprisingly, that patients weaned at different paces. So, for example, a high cervical spine injury is going to wean much slower than a low cervical spine injury. They did find that often patients needed higher ventilator pressures when they were on ventilation to accommodate a wean. So they often felt that they needed to put pressures up so that when the patients were resting, they got the extra support they needed. And they also found there were no adverse effects to tidal volumes of up to 20 mils a kilo, which does again feel very big, but there are some studies out there which do suggest there aren't adverse effects to that. Going forward, from a weaning point of view, Risky are now coming together to write updated weaning guidelines, and the plan was for it to come out at the end of last year, although nothing's been published in that period, so hopefully that will be out soon. And the difference with this weaning guideline from the Southport weaning guideline is that they're going to differentiate between patients a bit more clearly. So there's going to be differentiation between patients who are C2 to C5 injuries and C6 and below, and there's also going to be quicker weaning for patients with a higher starting FVC. They're going to recommend no weaning until the patient is cuffed down on the ventilator, and they're going to recommend limiting rehab and allowing rest overnight to prioritise weaning. They would encourage regular salbutamol nebs prior to ventilator-free breathing to optimise the airway and the lungs. And they recommended a gastrostomy to be put in place to help with issues with secretions that can be associated with NG tubes, and because they sometimes are needed for discharge anyway, and if not, they're easy enough to remove. Finally, in the updated weaning guidelines, they're planning on saying about the need of regular chest physiotherapy in the form of mucolytics, plus minus NAC, and regular physio by both the physio team and nursing staff. So in terms of next steps with this, the plan was to publish this at the end of last year, but that's not happened. And they are keen to raise their profile on social media and with referring centres to help spread the message and get more of the referring centres following these guidelines. There was then a talk by a dietitian, which I'm just going to briefly touch on because it's very much not my area of expertise. But he was a professor based at Stoke Mandeville, and he found that 44% of spinal admissions are at risk of malnutrition, although actually anecdotally I would have thought it was higher than that. We all know that malnutrition is associated with an increased length of stay and an increased 12-month mortality. However, he said, and this is something that I have seen anecdotally with our patients we look after in the community, spinal patients do have a significantly lower calorie requirement because they have reduced energy expenditure. And because of that, spinal patients long-term are at increased risk of obesity, which is then going to lead to significant knock-on effects. If they are obese, they're going to have greater risks of cardiovascular issues and skin disorders, which is then going to, again, increase their length of stay. And this dietitian then spoke about lots of tools and guidelines which can help to estimate a patient's new calorie requirements. But he felt that the average calorie requirement falls by 10% post-injury. Okay, So in terms of looking after the lungs, we spoke about weaning from ventilation, but what about respiratory care in general? There was a really good talk by Dr. Prasad, one of the respiratory consultants at Stoke Mandeville, who quite rightly pointed out that, as we know, the main cause of death in cervical spine injury is respiratory. We know these patients are at higher risk because of respiratory muscle paralysis, their ineffective cough, and high risk of sputum retention. To counter this, at Stoke Mandeville, they have weekly ward rounds, which consist of a spinal consultant, an ITU consultant, a respiratory consultant, and an advanced physio practitioner. This allows them to have an MDT approach to managing the patient and ensure that holistically all factors are considered. From a respiratory point of view, they advocate for following the NICE guidelines for bronchiectasis because they feel there's a lot of overlap in the disease and they have recurrent infections and often grow gram-negative organisms, which can be more drug resistant. Because of this, they recommend starting prophylactic antibiotics in the form of azithromycin or colimycin in patients who grow pseudomonas or have 3 or more chest infections per year. Whereas I know certainly here in respiratory at Glenfield, we tend to do it if they have pseudomonas and 3 infections in a year. Since starting this, they've noticed reports of improved quality of life and feel that their patients have reduced chest infections. In terms of managing patients with collapse, a local audit done at Stoke Mandeville found that in terms of bronchoscopy, if the collapse is more recent than 6 months, if it's less than 6 months old, bronchoscopy usually has good effects and they have a very low threshold to do a bronch. Whereas in patients with a more chronic collapse of greater than 6 months, it has minimal impact and they tend to manage it with antibiotics, physio and mucolytics. They often use NIV prophylactically to help with lung volumes and reduce chest infections. And we know both they commented on it from our experience here in the ventilation team, we would ventilate all complete C3 spinal cord injuries, most C4 and some C5. And those decisions with C5 are much more subjective. It's obviously hugely based on patient preference. And the other things we would consider when we're sort of guiding a patient towards a decision would be things like their vital capacity, their blood gases, their sputum production, comorbidities, their age, and their imaging. We know that patients who are younger and have less comorbidities are less likely to need ventilatory support, but often with these patients it is down to patient preference. In terms of monitoring these patients long term, we would encourage regular spirometry, which is easy to do. There's no guidelines on how frequently it should be done, but certainly if there are any signs of deterioration, it should be repeated. Sputum should regularly be tested and any changes should be treated. And we certainly here would use mucolytics and physio in the community and keep a really close eye on number of infections. And again, have a low threshold for starting prophylactic antibiotics. We'd complete regular ABGs, or in our case, capillary blood gases, to look for trends, rising PCO2 at night and bicarbonate rises, and complete imaging to help identify persistent areas of collapse, which are going to result in increased risk of infection, and also help to identify other lung pathologies. And it's, of course, essential to manage other comorbidities. From experience, it's never too late to ventilate these patients, and patients who initially don't want ventilating and maybe leave hospital without NIV go on to have atelectasis, collapse, recurrent infections and admissions, and that actually when patients then maybe down the line started on NIV, they go on to feel less breathless, they have less infections, they have a better quality of life, and often they live for longer. And I think one of the key takeaways from my job really is that ventilation certainly isn't a death sentence. These patients can have a really good quality of life, and it can certainly be a huge aid to them. Okay. So I did touch earlier on the fact that patients who have spinal cord injuries are to sleep apnea. And that's because they have reduced airflow as a result of their respiratory muscle weakness, and they are also at higher risk of airway obstruction and hypopneas during sleep. We also know anecdotally that these patients tend to be very poorly compliant with CPAP. And therefore we have to advocate lifestyle changes. These are things that I know on ITU are done really well already, so I won't touch too much on them, but things like regular sleep pattern, daylight exposure, avoiding evening stimulants such as smoking, alcohol and caffeine, avoiding daytime naps, and not going to bed hungry or full can all be really helpful. Okay, so when these patients leave hospital, it's good to have a rough idea of how long we should expect them to live. and I guess that's useful to have guide conversations with patients when they're acutely unwell. Southport did an audit of all of their patients over a multi-year period who were ventilated on discharge from their hospital. And they had 64 patients who left their spinal centre on ventilation, be it tracheoventilation or non-invasive ventilation. Of those 64 patients, 41 of those were the most severe with an ASIA A grading of injury. 72% were male. There was a median age of 38, and the median survival was 7.5 years. When that's broken down into injury level, we know that, well, they told us that their patients who had a C0 to 2 injury had a survival length of 7,500 days, which was significantly greater than patients with a C5 to 6 injury, whose median survival was only 1,300. And at the time, this really surprised me, because I suppose in my head, I thought that the higher the injury, the more dependent and the more physically disabled the patient is, so the less we would expect them to live. However, the reason they felt for this was that the higher injuries are almost certainly going to be ventilator dependent, which means that they're going to ventilate better, they're going to have a reduced risk of atelectasis and collapse, they're going to have a reduced risk of infection and respiratory failure, and they're also likely to have 24/7 care. Another factor in this group is that they are generally significantly younger, and that's because the patients who are older and have a C0 to 2 injury are much less likely to make it out of hospital alive. Additionally, the C5 to 6 group were significantly older, and more of them were discharged into care homes. And that was a really significant factor, discharge destination. Patients who were discharged home had a median survival of just over 7,000 days, whereas patients discharged to a nursing home had a median survival of just under 1,500 days. In total, 89% of their patients survived for 1 year after discharge, and 46% of their patients survived for 10 years after discharge. Other factors which were discussed were that patients who were discharged with enteral feeding are at much greater risk of death. However, patients who are discharged with enteral and oral feeding combined are at an even higher risk of death. Patients who had nocturnal NIV had a shorter survival period than those with 24-hour ventilation, which again comes back to the idea that they're more likely to go into respiratory failure, but that the main factor in survival duration was age. And I think I've summarised that on the next slide. So the significant factors are age, comorbidities, discharge destination, feeding, and the amount of ventilation required. So just coming on to a little bit of physio stuff at the end, because I am a physio and I have to include that. Thinking about normal cough augmentation, we would say there are 3 phases to a cough. So you've got your insufflation phase, where the diaphragm contracts and flattens, your external intercostals contract, and air enters the lung. You've then got the compression stage, where the epiglottis closes to cover up the trachea, which causes interthoracic pressure to increase. And finally, there's the exsufflation phase, where the diaphragm relaxes and recoils, the abdominals and internal intercostals contract, and that increases the interthoracic pressure. The epiglottis then opens and air travels down the diffusion gradient, taking sputum with it. So coming back to the muscles of breathing, typically we would only really think about airway clearance and cough augmentation with the high cervical spine patients. But actually, when you think about the importance of the abdominals, the intercostals during the cough, it can have an impact on patients with injuries as low as the thoracic spine, particularly if they have an infection, which is also going to reduce their cough strength. It's therefore really important that peak cough flow is being regularly measured, and that anyone with a peak cough flow of certainly below 200 litres a minute is given some cough augmentation support. I'm not going to go through the physio interventions because I don't think there's any physios here, but the physio interventions that you will be familiar with seeing on the unit would be things like regular mucolytics, breath stacking, an OVR bag, and really if the patient's on ICU, they're almost certainly going to be using a cough assist device. Skip past that. So that's about everything I had to say, actually. I guess the main takeaways that I took for this are that patients shouldn't be rushed. We should only wean these patients when they're ready and when their lung fields are clear, their oxygen levels are low, and they're doing some spontaneous breathing. We need to make sure we're not overfeeding these patients and thinking about weight management. And we need to make sure we're doing the basics of education around sleep and good sleep health. Thank you very much. Has anyone got any questions?
Just a quick question going back to the 15 mils per kilo. That will obviously, for most intensivists, sort of put an exclamation mark in their head. Is that maintained throughout the respiratory support, or was that with cuff down ventilation? Because obviously the evidence we have in a generic ICU population would be the risk of ventilator-induced lung injury at those type of volumes. So all our teaching is around avoiding barotrauma and body trauma, and using PEEP to avoid atelecta trauma rather than very high tidal volume. So that sort of in a general ICU population would worry us. Any thoughts on that?
Yeah, I would agree, actually. That was one of my takeaways on the day. I mean, the course was this time last year, actually. So my gut instinct is that 15 mil is far too big. I agree. I think the risk of trauma, I think there's other ways to mitigate atelectasis and collapse. And I think the new guidelines they're bringing out about maybe being able to wean with a higher PEEP, like a PEEP of up to 8, perhaps. That to me seems like a safer and equally effective way of preventing atelectasis and collapse. I guess, there's no harm in aiming on the higher end of normal for a kilo of ideal body weight, but 15 does seem big to me. But there is evidence out there that there's a relatively low risk of barotrauma in these patients. I can send over the slides, and there's some references, and there was some evidence they did share on the day.
Yeah. So am I right in thinking the old teaching for spinal injuries was volume control ventilation rather than I think you said pressure control. In my limited knowledge of spinal injuries, we used to get taught volume control in these patients.
Yeah, certainly. If you've got volume control, then you're going to know exactly what you're giving the patient. I guess when you are cuffed down ventilating these patients, certainly from our point of view with long-term patients, if they're cuffed down, we would tend to avoid volume control where possible, because the volume measurements aren't going to be as accurate. I don't know what it's like on the Dragers, but certainly with our community ventilators, when cuffed down, it's not going to be accurate. So that's when we'd go more to a pressure control bone. But no, volume control, you know what you're going to give, aren't you? So that sounds sensible.
That's interesting. Thank you.
Okay, thank you.
Thanks very much. Thanks. That was great.
Thank you very much, everyone. Thank you for that. Cheers.
Today, the general club topic is about a study called the Brain Vent. So it is a study about analyzing the effect of neurological and respiratory effect using low ventilation, lung protective ventilation in acute brain injury patients without lung injuries. Okay. So what is the background for this study to be conducted? So usually till now there is no ventilation strategies for acute brain injury patients. Like there is no protocol for what kind of ventilations to be followed for an acute brain injury patients. So there was a recent recommendation that lung protective ventilation should be used for all kind of acute brain injury patients. So that's why I think the study was conducted. So before going into that, just a little bit of background: what is lung protective ventilation and what are the effects of lung protective ventilation? So lung protective ventilation is something which comprises of low tidal volume and high PEEP. This is usually used for the settings in acute lung injury like ARDS. So the advantages of lung protective ventilation is it improves oxygenation and also it decreases the chances of atelectasis, helping again improving the oxygenation. But the drawback of this lung protective ventilation is because there is an increase in intrathoracic pressure, there is going to be a decrease in venous return, and this decrease in venous return is in turn going to increase the intracranial pressure, and which in turn causes problem in cerebral blood flow, and there is also impairs the cerebral autoregulation. So this is the main reason why most of the times lung protective ventilation is not useful in patients who had acute brain injury. But so we can use any other ventilation, but the problem is almost 35% of the acute brain injury is associated with acute lung injury because of the systemic inflammatory response and other things which involve. So eventually the patient with brain injury going to end up with acute lung injury. So there was no study which was done on acute acute brain injury patients with lung protective ventilation. There was a recent recommendation, as I told earlier, that lung protective ventilation should be used in all kind of brain injury patients, but it was not backed up by any evidence. So they came up with a study to provide evidence for this recommendation. So this study, what is the clinical question which was answered from this study was, The main aim of the study was to understand the pathophysiology of neurological and respiratory outcomes when using a lung protective ventilation, which was monitored by using transpulmonary pressure, brain oxygenation, and intracranial pressure, and other waveform analysis from intracranial pressure. We will see in detail about what all these things, measurements which they taken into account. So hypothesis of the study was lung protective ventilation did not increase the ICP. That was the main hypothesis, and that's how they proceeded with the study. And the baseline ICP pressure which they chose was 22 millimeter of mercury, and anything above anything above 25 millimeter of mercury was considered as a significant increase in intracranial pressure. So this study is a single-centered, randomized, and crossover interventional study. It was conducted in 2019, in between 2019 to 2021 in Norway. So the sample size for the study was based upon calculated using all the standard deviation, alpha error, beta risk, and they found out optimal sample size for this patient is 28 patients. Sample size is 28 patients. As it was a crossover study, large number of population sample size was not needed. So to be on a safer side, to include the dropouts and everything, they took a sample size of 30 patients. So the inclusion criteria is being all intubated patients with acute brain injury who require intracranial pressure monitoring were included in the study. The exclusion criteria were: one is increased intracranial pressure, and obviously patient with lung injuries and cardiac failure, and extremely obese patients with BMI greater than 35, and other patients with brain injury but who had extraventricular drainage or any procedures which done to relieve their intracranial pressure. So these were the exclusion criteria. And randomization for the study was performed using online software called RedCap, and the stratification was done with age and the type of brain injury, so less than 70 and more than 70, and what type of brain injury, either it is a traumatic brain injury or it is an acute subarachnoid hemorrhage. So they stratified according to the type of brain injury and then randomized the patient into two groups. So this group was divided and two interventions were planned. So the first intervention is low tidal volume, that is the tidal volume 4 to 6 ml per kg with low peak, 5 centimeter of water, and low tidal volume and high peak is the second group. That is also the tidal volume is being 4 to 6 ml per kg and the high peak is being 12. So between each intervention, they had a baseline period as well. So the first, once the patient has been randomized, they did a baseline ventilation with this setting, peak of 5 and tidal volume of 9 to normalize the blood gas, and then they are subjected to intervention over a period of 90 minutes. And then again, they did a baseline ventilation for a period of another 60 minutes to normalize the blood gas and cross over to the low tidal volume and high peak or the vice versa. So what are the things which they measured in this after randomizing this patient? So one with low tidal volume and low peak and another with low tidal volume high peak. So once these things are crossed over and the study and measurements are taken, so the measurements which they took are neurological and respiratory measurements were taken into account. First, initially they considered taking only ICP, but considering only ICP as a single value to determine the neurological effect is of limited value. So they went on to add a few more neurological parameters. So the first parameter is being cerebral reactivity index or PRX. So the PRS is nothing but indirect measure of cerebral auto-regulation. So it gives you an idea that how the brain adapts for blood flow, even in when the intracranial pressure rises. And the second one, which they, the third one, which they took is a compensatory reserve index. As you can see, the compensatory reserve index is a surrogate or indirect measure of cerebral compliance. And the final one, which they wanted to measure, was cerebral regional oxygenation saturation. So these are the four components which they took for neurological measurement. And for respiratory, they took only two parameters, one being transpulmonary pressure and another being mechanical power. So mechanical power can be explained as the amount of energy delivered to the patient over a period of during mechanical ventilation. So it's just a crude method of crude way of assessing what is the mortality or morbidity of the patient. So if mechanical power over a period of time exceeds 17 joules per kg per minute, they found out that the mortality was higher during the stay in ICU. So that's what so that they took into account as well in this study. So these neurological parameters was measured using the invasive intracranial monitor. The cerebral reactivity index and this compliance was measured using waveform analysis of intracranial pressure and ABP, and applying Fisher transformation on those waveform analysis. And then they found out the values for these. So the cerebral reactivity index, as I told you earlier, it is an indirect measure of cerebral autoregulation. So higher the PRX value, poorer the outcome. And similarly, higher the value of RAP, or the conservative reserve index, poorer the value, poorer the compliance. And finally, the cerebral regional oxygenation saturation was measured using near infrared spectroscopy. You can see here, just they attached it and they found out. And this was all these data was analyzed using software called ICM Plus, which was developed by University of Cambridge, and this is one of the most widely used neuromonitoring software all over the world. So it just takes data from all the monitors and analyzes. The main waveform analysis which this software uses is Fisher transform. It's one of the most widely used waveform analysis, even in all kind of procedures, from medical to even from our day-to-day mobile functioning. This Fisher transformation is used. So after this neurological measurement, the respiratory measurements were which were taken into account were, as I told you, transpulmonary pressure and respiratory mechanics. Transpulmonary pressure was measured using the difference between esophageal and airway pressure, and the respiratory mechanics was calculated. That is, the mechanical power was calculated using this formula. So once after taking all these measurements into account, the main primary outcome of this study is the finding out the effect of lung protective ventilation on intracranial pressure and cerebral reactivity index. That is how intracranial pressure and cerebral autoregulation gets affected by this ventilation strategy. And to have an endpoint for these things, they identified three parameters. One is how many patients were below the safety limit of intracranial pressure. In this study, they kept the intracranial pressure to a value of less than 22 millimeter of mercury. So they found out and calculated how many patients were below the level. And the second one is how many patients had a significant increase in intracranial pressure. That is, they took here it as more than 3 millimeter of mercury from the baseline, or from more than 22 millimeter of mercury. And finally, is there any relationship between increase in ICP and increase in cerebral autoregulation? So all these three endpoints were taken into account. And the secondary outcome they wanted to measure was compensatory reserve index, that is the cerebral compliance. As we can see, as the ICP rises, the cerebral compliance decreases. So that they wanted to measure that as well. And finally, brain oxygenation, which was measured using near infrared spectroscopy. The statistical analysis which they used in this study is for neurological and respiratory parameters. They used the PAR t-test and Wilcoxon sign rank test, and the probability, as you know, values less than 0.05 was considered significant. And once the group was divided, and once they were taken into account, and once the study was started, they are divided into two groups. That is called interrupted group and the completed group. And I will explain in detail what these two groups are. So this is, can you, I don't think you can see it, but I will explain to you. So two groups was divided, A and B. The first group was subjected to low tidal volume and low PEEP, that is PEEP of 5 and tidal volume of 6 ml per kg, and found out how many people had increase in ICP. And it was found out that there were none of them had increase in ICP. Whereas the other group, three had a significant increase in ICP. And after a cool down period, they were crossover was done, and found out that both the groups had almost significant increase in ICP. That is, two people in this high PEEP group and in the low PEEP group also had an increase in ICP. So when patient had increase in ICP, they interrupted the study and made sure all the values are brought down to baseline to prevent injury and to prevent poor neurological outcome. So that's why they divided the group as interrupted group and completed group. And they compared this interrupted group and completed group using Mann-Whitney U test and analyzed the result. So and we'll see this result after some time.
You say that the group before the crossover, the low tide of volume and low P,
Yeah.
they didn't have an increase in ICP.
Yeah. So
But during crossover,
yeah, they had a significant increase in
when
ICP.
they had the high P.
Yeah. So from low PEEP, they went into high PEEP. They had an increase in ICP,
Okay.
and same way when we crossover, there was increase in ICP.
So when they, so the other group, like say the B, which had a high, low tidal volume and high P, then they crossed over to a low P.
Low PEEP. Still they had had an increase in ICP. Yeah. Yeah. Only one patient got excluded because the patient developed pneumothorax. Rest of them were divided into these two group analysis was made. And so as you can see the result, out of 27 patients, 21 of the patients, irrespective of the PEEP, as I told you, right, whatever the PEEP, low PEEP or high PEEP, developed a clinically significant increase in intracranial pressure. But when this intracranial pressure was extrapolated with other parameters, the cerebral reactivity index, that is, which is the indirect measure of cerebral blood flow, there was no significant correlation. So I can explain to you with the chart over here. This is a scatter plot explaining, showing this is the on the left hand side you can see the ICP, on the down one it is the mean PRX, and to remain PRX is cerebral blood flow. So you can see the red dots are the patient who had a significant increase in ICP, and here also these are the patients who had a significant increase in ICP. At the same way, when they at the same time when they measured the PRX for these patients who had ICP, you can see the value is quite negative. So even though there was an increase in ICP, this patient did not have any effect on cerebral autoregulation. So that means that his blood flow was not impaired. And same is similar, as you can see here also, the work value is not extremely high. The only one patient was in positive, rest of them all are in negative. So they concluded that even though when there's a significant increase in ICP, the autoregulation was not impaired, and cerebral blood flow is also not impaired. That's what they can see in this chart. You can see the ICP, there is a significant increase in ICP in both the groups, but as you can see PRX, there is nothing significant. So the thing which they concluded from this was, even though there was an increase in ICP, there was no effect of blood flow, compromise in blood flow to these patients, and completely there was no significant difference in compliance and oxygen saturation. Only two patients had a decrease in oxygen saturation on the left side, left cerebral hemisphere, but it was not clinically relevant or clinically significant. So the only clinical significant finding was increase in ICP with low tidal volume and high PEEP factor, high PEEP ventilation strategy, but it does not cause any significant increase in compromise in blood flow. And once this neurological factors analyzed, they went into analyze the respiratory mechanics. And respiratory mechanics, they found out that irrespective of tidal volume, but the high PEEP intervention had both increase in transpulmonary pressure and mechanical power, but that also didn't cause any significant increase in any significant damage to the clinical parameters or the neurological physiology. So when these transpulmonary pressure and mechanical power increased, but it did not significantly increase above the value which I was mentioned earlier, above 17 joules per kg per minute. So it was well below 13. So that is also not significant. So just to summarize, there was no adverse effect of lung productive ventilation either on ICP or on cerebral blood flow, irrespective of the PEEP values. And even though the patient exhibited transient increase in ICP and they had to be interrupted, it does not affect their neurological outcome. And the strengths. So what are the strengths of the study? So this was the first clinical study attempting to find out the effects of lung productive ventilation in acute brain injury patient who doesn't have any lung injury. So this was the first study which was conducted, and during the study they maintained a very tight EtCO2 so that the effect of PaCO2 is not affecting the intracranial pressure. So Even though they reduced the tidal volume, they compensated it for by increasing the respiratory rate, so maintaining a maintained ventilation and keeping a tight CO2 range of 34 to 36. And also, another strength is they made sure that all the patients are hemodynamically stable before going into the study. And another one which they found out was this is the first study which had a study the relationship between mechanical power and cerebral variables. No other study had done the correlation between respiratory mechanics and cerebral variables. So this is also another strength for the study. And as I told you, this was documented using ICM Plus software. It is a real-time monitoring. So they have provided the screenshots and everything for the public to see and analyze the report. And now coming to limitations, as you can see, limitations is obviously a single center study. So there is a limited sample size. So we can't extrapolating this to other populations going to be a little bit difficult. And other thing which they did not take into consideration was they didn't see what is the physiological response for high tidal volume and high peak intervention. So they just used low tidal volume with the high peak, but they didn't go for high tidal volume because they were worried the patient might develop pneumothorax or any other lung injury. And also they didn't record any brain tissue oxygenation. They just measured an cerebral blood flow oxygenation, but not brain tissue oxygenation, and also no cardiac output monitoring. To conclude, as I told you, lung protective ventilation strategy from this study, it's quite feasible, and it is not having any. Even though it is having effect on increases the intracranial pressure, it is definitely not affecting cerebral blood flow. So, lung protective ventilation strategy can be used in patients with acute brain injury, but it should be prioritized and it should be tailored for each patient, especially in patients with low brain compliance. This strategy might be a little bit what to say. It can cause more harm than good. But apart from that, generally to large amount of population, lung protective ventilation can be used without any side effects. And also, before implementing lung protective ventilation in brain injury patients, it's also important to take care into monitoring ETCO2, mechanical power, and ICP. All can be used to assess the effect of all these things. And that's it. Thank you. Is there any question? It was 2022 in Norway.
What was the journal?
It was critical. It was critical care open access, BMC open access journal.
I'm trying to put a lot of things into perspective. I'm just wondering. I know it said that there was no change in cerebral autoregulation, but we are looking at patients who had ICPs of 10 and significant ICP was arising 3. Would we expect any change in autoregulation in such cases because of the kind of patients they picked with like more of a normal?
No. The significant rise was not just not from the baseline. The significant rise they consider above 22.
Yeah. Oh, so it was not by more because you had said it's by more than 3 ICP of an increase by more than.
No, not from baseline. The set value of 22 millimeter. If the patient had 10.
So anything that had was
about 22. That was considered significant and should be a sustained one. So that's what I try to explain in this chart. You can see the ICP. So it's more than 20 in these 3 patients. So this was the significant rise. There was see, you can see the baseline value for this patient. It had gone up, but it was not significant because it was well below 22.
Yeah.
Only 3 patients had a significant ICP greater than 22. Okay, and they thought that 22 is going to the one which above 22 will cause decrease in cerebral blood flow. So they monitored cerebral reactivity index, the PRX. For the same patients, you can see it didn't change. So even though the ICP was high, the cerebral blood flow is not affected.
Especially monitoring ICP, isn't it? It doesn't seem to correlate with the other markers of cerebral diffusion.
So PEEP is the only thing which is affecting the increase in intracranial pressure. The tidal volume is not the one.
Yeah.
So
So take home message to consider, you know, we don't, obviously we're a general ICU on neuro, is not to be too aggressive with PEEP, maybe.
yeah.
Yeah.
Here they took the value of 5 and 6, 12.
Yeah.
So maybe in
Yeah.
between that we can
Yeah,
have some.
where most of our patients would be.
So we can have a value of 10.
Complex study.
Yeah, it's all complex.
And you've got to be a bit, as you rightly say, you've got to be a bit worried about the small numbers
Yeah.
and single sensor.
Single sensor.
But,
And monitor all these things. You need quite a intensive
Yeah.
monitoring
Yeah.
system.
Absolutely. Yeah. Thank you very much.
Thank you.
Thank you.